webinar. We may add some in the future. Please make sure your microphones are muted. We will be recording this, as you may have gathered. And today we are focusing on just a general Q&A. We've got some questions and answers teed up for you and all of our subject matter experts online for additional questions to be asked. So please make sure to put them in the chat. Go ahead and go to the next slide, Takina. The slide deck and the webinar recording will be available on our website, as it always is. And I think if we could get Rochelle if Rochelle's on here, would you mind dropping a link in the chat to the slide deck that we have up online? Thank you. Next slide, please. Again, this is an open forum for Q&As. We do have some things teed up for you based on questions you've asked at previous webinars. But we will make sure to spend some time at the end for any additional questions. Next slide, please. I'm sure you've seen this graphic many times by now, but as a reminder, the readiness assessment or milestone 3 is coming up here. It's due on April 4th. Please feel free to email the reentry inbox with any questions. We've already had some really good questions that I'm working on getting answers to. So please feel free to contact us, and we're happy to do some technical assistance. The other thing I'd like to point out is that if you are in cohort 2, your capacity building application is due April 1st. And if you would like to participate in cohort 3, May 1st is the deadline for submitting an intent to participate. Next slide, please. As you know, we have gone through many different topics throughout this webinar series, and we're going to go ahead and go over a few of the common questions asked relevant to each topic. Next slide, please. So we're going to go ahead and start off with provider enrollment, and I'm going to ask George to sort of speak to the pros and cons of using one NPI versus multiple, and sort of give us an understanding of when it's common to see one versus multiple. Thank you.
Sure. So first of all, I'll just go back a real high level. NPIs, National Provider Identifiers, are issued by the feds. And there's two kinds of NPIs. There's ones that's issued for individuals, and feds will only issue one NPI for an individual. And then there's one that's issued, one category that's issued for businesses or organizations. And the feds call them an organizational NPI. And that's what we're going to primarily talk about, is that what they call a type 2 or organizational NPI. So for the NPPS, the National Provider and National Plan and Provider Enumeration System, they will issue any number of NPIs that you request for a business or an organization. That will be up to you. Some providers will choose to set up their whole business under one NPI, everything, and that's fine. That's up to them. Or some businesses will choose to maybe get an NPI for different locations. Some of them will want to get an NPI for specific programs within a particular location, like a large facility like the University of Washington. I think they have a dozen or more organizational NPIs, all for the same location. And then some providers will go out and get an NPI for each location, each physical location. So that, again, that's going to be up to you as to how many NPIs that you want to get. So we'll talk a little bit about some of the pluses and minuses and challenges behind each of those choices. So let's say you roll up your entire business under one NPI, and you have, let's say, multiple locations that are going to participate in this program. you decide to roll the all of those locations and all your business under that one MPI, which from our standpoint and the Fed standpoint is going to be fine. Now, if you do that, all of the claims for those locations are going to be rolled up under a single remittance advice. And the challenge behind that is that especially on the fee for service side, you're not necessarily going to know which location those claims came from. That will be a lot more work for your office people if you do need to know what location they're coming from. The claims are from, you'll have to have somebody go chase down that manually. Some of the advantages is if you need to update your provider information, it's just that one provider record. Like let's say you change your banking information, you'd have to just go to that one provider record and update the banking information, and those kinds of things that would be simpler to update. And some providers, from a policy standpoint, they prefer the single MPI. There are providers out there that will use multiple MPIs. Now, that the advantage behind that is let's say you want to go out and get an MPI for every different location. When you bill for services, each location will have its own remittance advice. So the claims data will be tied specifically to that remittance advice. So it simplifies office staff work because you don't have to go out and chase down what location the payments are tied to. Some of the challenges behind that are if you make updates to provider information like banking information, they'll have to be made to each NPI location. Like if you change the banking information, you have to go into under each NPI and change the banking information separately. Now, there's some other positives with having a single MPI. Some large clinics that have multiple locations, they have like maybe a centralized office that does all of their claims work, and they want all of that information to go to that one particular office. That simplifies that side of the business because that all the claims and information will all go through that one MPI. And I think one of the other challenges with the multiple MPIs is that each MPI will have its own provider record, which will mean the people that go in there and access the provider information and the remittance advice and those kinds of things will have to have access to that provider record. Have to get separate credentials to get access to that provider record. And so that means, let's say you set up 5 different MPIs, each one of those would have to be maintained separately. You'd have to go out and get credentials for each of those 5 provider records. So it makes for more maintenance all the way around as far as getting access to provider one and updating those provider records. And then once you get access, if office staff change and stuff like that, you'll have to get them access to each of the provider records. So there's more maintenance on that side. So there's one other thing I want to emphasize here is that whichever method you choose, it's really important that when you contract with the MCO and you enroll with the state, that you use the same process for all of them. Like if you have one MPI that you want to roll everything up into one MPI, you just use that one MPI. Or if you're going to use multiple MPIs, that you use those same MPIs with both the MCOs and the provider enrollment. We've run into some issues in the past where providers have chosen to contract with a MCO differently than they have with us, and that's caused them billing problems. So that's the updates that I had. Is there any questions on that?
Go ahead, Kathy.
Hey, George, just want to confirm in regards to tax ID and submitting claims, the tax ID is not tied to one individual NPI, even at an organizational level, correct? So if we have 4 different jail clinics all under the same jail county entity, that tax ID can bill for all 4 organizational NPIs, and then the rendering and or providers would all be enrolled based on the location they service.
Yep, that's exactly correct.
Perfect. Thank you.
And this will be the same for the MCOs and the and provider one and HCA. You can have any number of organizational MPI tied to a single tax ID.
Thank you so much.
Thanks, George. Barry, go ahead.
Hi, I'm a physician in Colville, Northeast Washington. We have a private clinic that doesn't bill any insurance. That's a concierge model for people without insurance and low or high deductible insurance plans. We have a separate NPI number for our reentry work and recovery work. Is that the best model? And I think what you're saying is that by keeping that separate, the advantage is that the concierge, there'd be less confusion, it sounds like, in terms of expecting that getting the billing mixed up, because we don't do any billing of any insurance companies under the clinic. We would only be doing billing under the recovery and reentry work.
I think you've communicated this directly to me in writing, right? I think we've had a conversation on this.
Yes, we have.
Yeah. And I think I owe you a response. I went to the I escalated this and I haven't heard back. I owe you a response on this. I think that's going to be a little more complicated than either one of us are hoping, Doctor. But let me get back to you on that.
Okay, sounds like you got to take that offline.
Yes.
Thank you
Yes,
all. We'll move on to the next slide around MCO contracting and credentialing. Basically, this slide gets at specifically who is eligible for the 1-year credentialing grace period and helps us maybe understand a little bit better the contracting and credentialing process. So I'll go ahead and hand this over to Karen, and if Takina, you'd like to go to the next slide, that would be great.
Good morning. My name is Karen Buchanan with Healthcare Authority. I just want to talk a little bit about the questions you had on MCO contracting and credentialing. First, we'll talk a little bit about contracting. So I do want to answer that question on, is there a grace period for contracting? So there is no grace period for contracting. We do expect facilities and providers to establish a contractual relationship. And this allows you to bill for services to the MCO. And any carceral facilities providing reentry initiative services do have to contract with each MCO to be able to implement the initiative. We do not have a grace period that is allowed. Our regulations do not allow for that. There is different kinds of contracting. We will go through, I have a flow chart to go through once we've kind of discussed this a little bit, that will probably clarify it a bit more. Credentialing. So there is the possibility of a 1-year credentialing grace period for certain providers. It is required for everyone to credential with each MCO prior to entering a regular provider in-network contract. For facilities that have in-facility healthcare staff that are performing services, you can opt to delay the completion of the credentialing portion, but that's only for 1 year past implementation. However, if you're using community providers that are billing on their own, then you do have to have the community providers credentialed and contracted with the MCO separately. I do want to make sure that there is a little bit of clarification because I think there can sometimes be some confusion with credentialing on what that actually means. So credentialing in the aspects we're talking about are not, we're not talking about your license or your enrollment with HCA. So this is separate from your DOH licensing and separate from provider enrollment and your core provider agreement with HCA. This is a process that goes through the MCO where they look through a lot of documentation and they're double checking our license is current. Are there any complaints, anything that would prevent them from being able to do business? And those are the things that we can offer that 1 year grace period on. Things like your actual licensing and your core provider agreement with HCA, we cannot provide a grace period. There are regulations that do not allow for us to provide a grace period for those processes. I just want to clarify that in-facility healthcare staff, when we talk about that, means any provider that you are responsible as the entity for all of the servicing providers, including audit, recoupment, oversight of the provider. So this can be providers that are embedded directly in the facility. This could also be providers that are in the community, but you are acting as the billing entity. If you're taking on that billing entity responsibility, that does mean that you are also taking on that responsibility for oversight of that provider. Can we go to the next slide and we'll just kind of go through the flow sheet because I think that will answer questions a little better than just in speech. So there's really a couple of different routes you can go down for credentialing and contracting with the MCOs at this time. This flowchart kind of tries to capture that. There may be some instances that are not captured in this flowchart. I do want to mention right off the bat that this is not applicable to pharmacy. That is a separate conversation. So to start the flowchart, we're going to, are you providing healthcare services? Are they being provided by the carceral facility? So this is basically, are you the billing entity? If the answer is no, it's pretty simple. So billing will not occur through the carceral facility, and that takes us down that initial path at the top. If you're using community-based providers, they are going to have to directly credential and contract with each MCO, and they will be the ones who directly bill the MCO. What will be required of the carceral facility in this instance will be there will need to be a memorandum of understanding with the MCO to make sure that there are working relationships and processes in place for sharing of information between the carceral facility and the MCO. Now, if you are intending to provide healthcare services and you are the billing entity, then this is where you do need to be enrolled and have a core provider agreement with HCA and be known to provider one, and you're acting as the billing provider. You are able to leverage the TPA for support in these instances. We do expect that claims are submitted timely, just like we do for any healthcare provider. But once again, if you go this route and these are providers that are not already embedded within your facility, you do take on that role, whether they're embedded or not, as being the responsible for oversight of those providers. So that does include any audit responsibility. If there's recoupment, you would be the responsible entity. So if this is the route you're going, and you have providers that are available either in your facility or community providers that you are billing for, the question next is, are you ready to credential now or are we delaying? So if you're ready to credential now, you would need to go through the process to credential with each managed care plan. That would make you an in-network provider. You would then contract after you credentialed. And that can happen as soon as you'd like. That can just be done as soon as you are ready for it. If you are not ready to credential now and you want to take advantage of that 1-year grace period for credentialing, we do still have to have you contract with the MCO, but it'll be a different kind of contract. So this would be an out-of-network, non-par provider, but you would still be treated as in-network. So these would be single case agreements or multi-case agreements. This allows you to serve Apple Health clients that are enrolled in MCOs and allows you to act as the billing entity. It does give you 1 year to complete the credentialing process. You do not have to complete credentialing to enter into that single case agreement, but there is some minimal provider verification that is still required. They're still going to have to look and make sure that, of course, the providers are licensed. Some cons with doing this route are, of course, that this is only a temporary solution. You do still have to make sure that you credential within that first year because once you hit that 1-year point, the grace period ends and you do need to be credentialed and contracted directly with the MCO. I just want to also point out just that we do prohibit on single case agreements any payment that is greater than any other provider, so there is no ability to negotiate on single case agreements. Questions on these?
Karen, I think you cut out there for a second, but I think you were asking, does anyone have any additional follow-up questions here? Feel free to raise your hand or put it in the chat either way.
Hi, this is Erica Clyde with United Healthcare. Can you hear me okay? Sorry, I couldn't figure out how to raise my hand.
Yeah.
Okay, awesome. I put my questions in the chat. I know for UHC, we follow the NCQA CRED guidelines. We would prefer to contract directly and not do single case agreements. Are single case agreements a requirement?
Hi, Erica. I think this is maybe a question for the MCO forum that we have separately from the Reentry Initiative webinars.
Gotcha.
Is that
Okay,
okay? Can we take that
Yeah,
offline?
yeah, no
Thank you.
problem.
Okay. Do any facilities have additional questions around the contracting and credentialing piece? Aaron, looks like you explained it so well, no one has any questions. And we can maybe move on to Apple Health. Oh, go ahead. Hi, Ed. Go ahead.
Why do you guys say that like you regret me asking a question? Hey, the question
Absolutely not. Happy to hear from you.
I do have is I know the MCOs were working on all these MOUs and contracts. Do you have any idea of the timeline? We'll get an update on how that's going with all of our providers and so forth, or how do we know?
I do not have any information on that. I don't know if anyone else on the call does. Maybe something we need to take back.
Yeah, MCO partners, if you have a sense of this, please go ahead and speak up. Otherwise, Ed, love to have your question in writing and we can take that back.
Thank you.
All right, Takina, if you wouldn't mind moving on to the next slide. All right, this section is going to focus on Apple Health eligibility and enrollment. And we kind of want to clarify today what the difference between the two pathways for Apple Health applications are, and also how will a provider who is providing services for the Reentry Initiative know if an individual is within their 90-day pre-release period to be able to bill for services, whether this is different for fee-for-service or managed care. And I'll go ahead and pass this on to Tara and Tamara.
Yes, hi, Tamara is here with Eligibility Policy Innovation and Community Support Team with HCA. And today we'll go over some of the information that you may have been already familiar with to help with any concerns or any questions. Let's start with Apple Health Medicaid client eligibility and enrollment verification. That might be helpful information. So facilities have two ways to access Provider One and verify an individual's Apple Health eligibility and enrollment status. We have Provider One, where Apple Health billers or providers have direct access into Provider One by using the Provider One provider portal. And we have One Health Port, a secure portal where Medicaid billers or providers can access Provider One. Provider One allows access to such information as verifying client eligibility for Medicaid services, prior authorization, inquiries and submissions, claim inquiries or payments, view managed care enrollment, and this is also a tool to track 90-day eligibility for reentry services and billing. For more information on how to view eligibility and enrollment in Provider One, view the Provider One billing and resource guide. Next slide, please. For the purposes of eligibility and processing applications, Apple Health is divided into two application pathways: modified adjusted gross income or Magi-based programs and classic Apple Health programs. For Magi-based programs, eligibility criteria vary for each program and based on household size, tax filing status, and income. Apply for Magi-based coverage online through Washington Health Plan Finder for clients who are adults aged 19 to 64, applying for children, parents or caretaker applying for children, and pregnant or applying for someone who is pregnant. For classic Apple Health programs, eligibility and requirements vary for each program, considering income and resources. Apply for Apple Health Classic coverage online through Washington Connections for clients who are adults age 65 or older, eligible for Medicare, blind or disabled, or in need of long-term services and support. We're also listed some options facilities can use to support and facilitate individuals applying for both Apple Health Magi-based programs and Apple Health Classic. Facilities can train their staff to become a volunteer assister, or they can work with community assisters or navigators to be able to support individuals with Apple Health applications. Next slide. Thank you. Next, let's take a look at 90-day pre-release service scenarios. If an individual becomes incarcerated in DRC or JR facility, which is usually a long-term stay, they are placed in a suspended status and are eligible for pre-release services 90 days before their estimated release date. If an individual becomes incarcerated in a jail, which is usually a short-term stay, they are placed in a suspended status and are eligible for pre-release services for their first 90 days of incarceration. This will also apply for JD facilities when processes are in place. To accommodate changes in release date or in a carceral setting, the 90-day period of pre-release services may be restarted, which will give an individual a new 90-day period of pre-release benefits, regardless of how many days were used in the first set of 90 days. So let's look closer at those scenarios, kind of just going over through them. So when a client is incarcerated in a jail, they're eligible for reentry services from the day of booking and continue up to 90 days. When a client is incarcerated in a jail, receives an update to their ERD, they're eligible for reentry services 90 days prior to the updated ERD. When a client is released and rebooked the same day with no ERD or estimated release date, they're eligible for up to 90 days of reentry services for each unique booking. When a client is released from one jail and transferred to another jail without an ERD, they're eligible for up to 90 days of reentry services for each unique booking. When a client is transferred from a jail to a prison, they're eligible for reentry services 90 days prior to ERD at the prison. For more information around 90-day pre-release services, please refer to Reentry Policy and Operation Guide, which some of the sections are already available, or some of them will be released soon. That would be probably very helpful. That would be it for me. Thank you.
Thanks, Tamara. Takina, can you actually go back a slide? So you'd go back a slide, back 2 slides now. There we are. Okay. So we have a couple questions in chat. This will be for Tara or Tamara. The instructions I have seen say we can bill for services provided to patients eligible for Medicaid. Must they also be enrolled before we can bill?
Hi, this is Tara. Can you all hear me?
Yes, we can. Thanks, Tara.
So if they might have enrollment or they might be fee for service, right? So they don't have to be enrolled in a managed care. They could be, or just have the fee for service.
Brandy, does that help answer your question, or is there follow-up?
I guess my question was, if their coverage is suspended while they're incarcerated, how can they be enrolled at all?
Yeah.
Whether it's managed care or fee for service, I'm confused.
Yeah, so that is a part of the waiver where there's eligibility. So even though they'll show a suspension, they're in the benefit inquiry, it will also show that they have the inpatient services and waiver service reentry services available during those the 90 days period.
So eligible for reentry services, is that the same as they're enrolled, which means once they're released, they will be enrolled? Or
Yeah,
is
so
it, yeah.
Yeah, so I mean, if we can take a scenario if somebody is incarcerated and they are within 90 days, they would show a suspension in provider one, but they would also have their benefits of reentry services and inpatient services during that time, showing the enrollment in their managed care. If they release within those 90 days, they would remain in their managed care, but the benefit inquiry would change back to their full benefit.
And if
So
they were
unsuspended.
never enrolled, let's say they're incarcerated in a jail, were never enrolled in Medicaid services before, so there was nothing
Yes.
to be suspended. How do we make
Right,
sure
so
we can bill?
yeah, so there would be a submission of a Apple Health application,
Mhm.
right, to verify their eligibility.
So they do have to, we have to apply for them, and they have to be
Yes.
accepted / enrolled for reentry services before we can bill. It's not just that they're
Yeah.
eligible, you have to actually make them.
Yeah, the application, yep,
enrolled.
will show their eligibility.
Okay, thank you.
Thanks, Tara. We also have a question from Eric. What if these individuals do not have access to the required information, for example, AGI? This could be an issue with the required timelines. And I assume required timelines refers to checking eligibility or doing enrollment within that first, I think, 24 or 48 hours.
Yeah, so Eric, this would be right, the application, if somebody was Medicaid eligible, and you're asking about income, right? Are you able to come off mute?
He put it in the chat, but yes.
Oh,
that's-
did he? Oh, I can't see. Okay.
Sorry, I was having trouble finding my mute button.
Oh, no problem. Okay,
Yeah,
so if they,
specifically, somebody's not already enrolled, you have to submit the application within the required timelines. You're talking somebody that's coming and they're being incarcerated, they're not prepared for something like this versus if they're online at home filling out an application, or I mean, a lot of people don't know their adjusted gross income or a lot of this different information off of the top of their head, or they might not even know how to access it. So how do you meet those timelines and submit these applications when their eligibility is largely determined off of these things, when they may or may not have access to all the things they need to actually submit the application?
yeah, great question. So I think you can use the moment in time. So at that moment, right, you fill out the application as best as possible. When you have that information, you would need the individual, or if they're receiving assistance to fill out their application, could then update it.
Okay, thanks.
Just to get a little bit more granular to clarify, Tara, you're saying that once an individual is incarcerated, their income can be updated to reflect that they are not working, correct?
Yeah, if they're no longer working. Absolutely.
Great, thank you. Okay, we have a question from Kathy. If a patient is not enrolled in Apple Health and requires an application, when their application is approved, will their eligibility begin at booking or at the time the application is complete, which I think may be around the same time. But if you'd like to go ahead and address that, Tara, thank you.
Yeah, so okay. This is Kathy. Kathy's question requires that. Right, so I think I would turn to the waiver team on some of this if there's requirements around application, right? Assistance when they are booked, but their eligibility would begin as soon as they submit the application, right? If they are eligible, if they're found eligible.
Yeah, so just a little extra information, anticipating short-term bookings with the jail, with
Yeah.
most of the county jail systems. If they're booked, then a lot of those waiver 1115 services, reentry services will begin immediately. Curious if they would be billable or if the eligibility date would begin when the application was processed, and I'm not sure what that time frame is. How long does it take to process an application and receive approval for Medicaid benefits?
Yeah, so if you're processing through the health plan finder, it would be immediate that it would show, and then overnight would show in the system.
Thanks, Tara. I think that's super helpful. We have a question from Nicole, but I think that this is something we would like to take back. So I think we should, unless, do others have follow-up questions about the slides presented? Eric asked a question in the chat. Tara, he's suggesting another scenario where if someone is serving on weekends and released during the week. Eric, can you add some context, please?
Yeah, so there are cases where people are sentenced and they have jobs, so in order to serve their time, they come in and they're booked in on the weekends and then released on a Monday morning so that they can go to work, and they're out of the facility during the weekdays so that they can keep their job, but then they continue to serve and be booked in every weekend until their time is served. So I'm not sure how these benefits would apply to those. I mean, do they just continue to go in and out of a suspended status?
I think I understand. Can you say that one more time? I'm trying to make sure I understand the question entirely.
Okay, so scenario, somebody receives a sentence from the court, or they get like a provision where they have time to serve, but in order to keep their jobs, they're given the ability to still go to work. So in those cases, and I had a family member this actually happened to, they go in and they're booked in for the weekend and they serve time on the weekend, they're released during the week, and then they continue to serve on the weekends and be released during the week in order to work, so that they can keep
I
their
think it's
jobs.
kind of like a work release, but
Kind of, yeah.
but slightly different. I'm going to take this one back, Eric. It's a really great question. So I will follow up with that one.
Thanks, Eric. Thanks, Tara. Nicole, I think Tara is comfortable answering your question, which essentially is asking if an inmate is uncooperative combative, or you need to wait to get fingerprints back to identify the inmate. What do you do with the 24-hour enrollment and screening requirement?
Yeah, Nicole. So I would think you would process the application for eligibility as soon as you're able to. You would still need to receive some of that information, right, to screen for their application and eligibility.
Thanks, Tara. Does anyone have any additional questions before we move on to the next slide?
This is Brandy DeFazio from King County again. I just want to reiterate on that last question that it sounds like that means the initial screening services might not be reimbursable if we have to provide those services before the application can be submitted. Is that something you guys are going to take back and reconsider?
I can jump into that, Tara.
Yeah. Yeah.
So separate from the eligibility component that Tara is addressing now, another requirement of the program, as Brandy's laying out, is a reentry health screening that's required to participate in the program. Clients need to be screened within 24 hours of becoming eligible, and that is not a billable service. So to your point, Brandy, yes, it is a requirement of the program, and it is not specifically a reimbursable paid Medicaid service.
Okay, that's new information. Thank you.
I'm going to go ahead and move us along. I see another question in the chat from Brooke, but we do have a line of communication with the OC that we can get some Q&As handled sort of separately from this. So Takina, if you could go ahead and go to the next slide. This focuses on the Consolidated Appropriations Act of 2023. Specifically, this is going to primarily affect juvenile detention facilities, but can very well impact adult facilities. So the question is, what are participating facilities required participating in the Reentry Initiative to provide to CAA eligible individuals as a part of the Reentry Initiative? And does this apply to adult facilities? And I'll go ahead and pass this off to Colette or Tara, whoever wants to take this. I was assuming Colette would.
Thanks, Michaela. Yes, I'd love to jump in here, and I welcome Tara as my partner here to make sure that we have the full picture for everybody. And I should have introduced myself already. I'm Colette Jones. I am a nurse manager here at the Healthcare Authority in the Medicaid programs team. Thank you. Next slide, please. Okay, so what do you have to do for the CAA work? That is the question. In addition to the 3 mandatory reentry services in our other benefits, in our other benefit webinar, we also introduced that there are 2 additional benefits that are required in order to be complete and address all of the CAA mandates. What that looks like is services both pre-adjudication and 30 days pre-release, in addition to the targeted case management. I'll show you on the next slide in a second. But those 5 services are all mandatory in order to participate for the Reentry Initiative services. So just to be more concrete about what clients we're talking about, these are primarily juveniles, so you'll often hear this referred to as a juvenile initiative. However, I want to note that there are adults in this group too. Eligible juveniles under the CAA include clients that are eligible for Medicaid or the Children's Health Insurance Program, or CHIP, up to through age 20. And also Medicaid clients between the ages of 18 and up to 26 who aged out of foster care when they were on their 18th birthday. We call that population the alumni. Tara, anything else you want to jump in here about the population?
Nope, you covered it. Thanks, Colette.
Thanks. Next slide, please, and let's talk about the services a bit more. Okay, so there are 2 concepts here. You'll hear these terms 5122, 5121. That is referring to whether or not the client is pre-adjudication or post-adjudication. Depending on your facility type, that helps you know whether or not you're addressing this population or not. This, because of that age range, goes into the adulthood. This could impact all facility types. So all facilities need to be aware of what these requirements are and look for that age and eligibility to help support this population. But primarily our juvenile focused facilities really need to hone in here. So the pre-adjudication package, which is called the 5122 section of CAA, those are Apple Health benefits, and those are beyond the Reentry Initiative set of services. So typically we talk about the Reentry Initiative services as a limited benefit package, that they are really focused in on certain aspects that are allowable under this waiver. CAA allows us to go beyond that and provide what's medically necessary and appropriate in a carceral setting. Still really focused in on the same kinds of concepts we've been talking about, like screening for urgent care needs and assessment and evaluation, those kinds of concepts to get kids into the right care, supported, identifying needs, connected to care, all of those kinds of concepts. But there's a lot more flexibility under this piece to allow kids early access to care. Okay, that's pre-adjudication. Then once the client is post-adjudication and within our 90-day period, okay, I'm going to tell you there's a timeline here. Don't get confused by the timeline. The CAA talks about a 30-day period, but our waiver allows us a broader sweep here. So we can provide services up to 90 days pre-release. Same thing as in the Reentry Initiative. So this is allowing that clinical assessment and evaluation concept we've talked about in those benefit webinars to be available 90 days pre-release. And because we know this population is often in and out really quickly, and it's hard to get services really timely in there if they're in for a matter of hours or days, there is also a pressure valve, I'll say, that allows for services to get connected no later than 7 days post-release or as soon as practicable, right? So sometimes it is hard to get this all arranged, but the goal here is getting these services upfront in the carceral setting and really supporting access to care and services early. That is all I had. Any questions on that? Or Tara, anything else? Jump in.
No, we did. Nope, covered everything. Thank you.
Great, thank you.
Nori, go ahead.
Thank you. Good morning, everyone. For clarification, under 5122 for our pre-adjudicated kids in county detention facilities, is there no 90-day pre-release requirement there? So if we think the kid's going to be out in 95 days, we can provide services under CAA, correct?
Okay, let me pull that apart. So pre-adjudication doesn't have a time window. It doesn't matter how long the kid's in. So I think that's what you're saying?
Yep, just making sure it does away with that time window restriction. Just wanted to clarify that for pre-adjudicated youth.
That's such a great question. Thank you. The other answer I would give to that is the 90 days pre-release is not deciphering that pre and post thing. So it is 90 days pre-release, giving you a little bit more flexibility there. Oftentimes, I know the estimated release date is not yet known. You're operating under, all the pieces of information you have. But that pre-adjudication, yes, you have a bandwidth here to do the services that you need to do.
Thank you.
Thanks.
Jody, go ahead.
Yes, good morning. And under the post-adjudication, under CAA, does that also include 30 days of targeted case management?
Thank you, Jody. I so appreciate that question. So the CAA, as a federal legislation, requires certain things. It requires targeted case management, requires screening, diagnosis, those kinds of concepts. The way we've put that together in this reentry initiative is targeted case management is required as one of the mandatory reentry initiative services. That's 90 days pre-release. Yes. In addition, there are additional elements that are needed for our CAA population, and that's the clinical assessment and evaluation piece. So your answer is yes, targeted case management is needed for this population and for the rest of the population too.
But it was more on the post-release section that I thought that was an additional case management requirements post-release under CAA.
Got it. Yes. So the way, thank you, Jody, for that clarity. The way targeted case management is set up and required in our federal authorities is that it is focused in on that pre-release time period, really getting supports in there, coordinating everything, supporting that transition to the community. It also requires follow-up with after that transition occurs to ensure that the client's care and services are connected and they are engaged in services and happening as the plan required. That is true for the entirety of the Reentry Initiative. So there is a pre and a post component. You'll often hear these talked about as pre-release benefits, but really case management is most effective when then you follow up with that client to ensure that it's occurring. So that is a requirement, yes, of the CAA specifically, and it is a requirement for the entirety of the Reentry Initiative population.
Thanks, Colette.
Great.
Do folks have additional questions around the CAA? Okay, if not, we will move on to the next slide. This is around that 30-day supply of medication requirement. How do we comply with the 30-day supply of medication in hand at release requirement? Individuals are often released unexpectedly or outside of pharmacy business hours. Would there be guidelines in the P&O guide or best practices that can help? And Colette, I believe I'd like you to take this one as well, if you can. And Takina, if you could go ahead and move to the next slide, that'd be great.
I love this question. I know that this has been an area of concern because pharmacy business hours aren't 24/7 in all regions. So we want to make sure that we are doing our due diligence here and supporting you and knowing how to navigate that. So in the policy and ops guide, there's going to be a great information on this to back this conversation up. But in brief, that 30-day fill requirement applies whenever feasible because of pharmacy access. So if a client is released during pharmacy business hours, and that's either planned or unexpected, either way, or that client is released after hours, but you knew to expect it, it's a planned release time. And that way, coordination with that pharmacy can occur prior to that and get that fill of medications. So both of those circumstances are when that 30-day fill is needed. And then we know that care and releases happen outside of those pharmacy hours. So when that does occur, there is a requirement to give that client a choice. They can decide to come to the carceral facility for the next pharmacy business day and pick up those medications, or they can choose to identify a community pharmacy that can access that 30-day medication supply. And then the carceral facility is required to coordinate to make sure that that script is on file at that pharmacy. And like I said, this is built out with a little bit more details in writing in that policy and ops guide, which will come out shortly. Any questions on that?
Yeah, Rich, does that answer your question that you put in chat? All right, Nicole's
Yes,
asking.
thank you.
Okay, great. Thank you, Rich. Nicole's asking, in one of the earlier webinars, it was discussed that you could give them enough medication to get to their appointment. Is this no longer acceptable?
So the 30-day fill is required. And further, sometimes it is necessary because the appointment is, an additional segment away or what have you. So that should be part of the consideration in what that script looks like from the prescriber to help support that client have that continuity of care and get connected back to the community prescriber. But yes, that 30-day fill does apply.
What we were told, and we had a conversation with Dr. Mark Stein yesterday, is and our doctor's concern as well, is there's certain medications we should not be giving them for 30 days. As well as there's certain conditions that we're maybe briefly starting them on medication, but it would not be, again, appropriate to give them 30 days of medications. So we were under the exception of if we made them appointments prior to leaving, we could get them medication up until that point, and then they would need to go to their appointment. So you're saying that that's not correct. They have to have 30 days of medication.
So pharmacy is very complex, right? And prescribers have great ability and training and competency to evaluate what's appropriate in that situation. In addition, there's regulations and policy that might play in. And there's more detail in this on this topic in the policy and op guide for you to read later. But what I would say is sometimes it's clinically inappropriate, just like Dr. Stern is saying, to prescribe a 30-day fill. And we want our clinicians to have the full authority to address the care and services that are appropriate. So what that might mean is, obviously here's an extreme example is, a 14-day fill of antibiotics. You wouldn't be doing a 30-day fill of antibiotics. That wouldn't be reasonable in all circumstances. However, when it is medically necessary for that client and allowable under regulations, yes, that would be necessary. There are going to be circumstances that need to be coordinated with that prescriber to figure out how that client can best connect to the next care and services.
Paulette, I think that was really helpful and good articulation of clinical judgment. So we have another question in the chat, and after that, we will probably have to wrap this up. So if anyone has additional questions, please put them in the chat and we'll try to get to them in these next 2 minutes. But we do have a question from Anna regarding the facility can give the client 2 options. Does the facility, can the facility pick one of the options? Pick one of the 2, or facilities have to offer both? Yes.
Great question, Anna. Thank you. This is the client's choice. So this is up to the client to decide which is the most appropriate for them. Some clients won't want to come back to the carceral facility. Some clients don't have a community pharmacy yet figured out. So it is up to that client to figure out what is best for them in that moment. And the carceral facility is asked to support and ensure that access. Thanks.
Does anyone have any final questions before we close out here? Okay, well, I appreciate everyone's attendance. We will update the slide deck and repost on the Reentry Initiative website by the end of today. I appreciate everyone's time, and thank you to all the subject matter experts that helped us with questions and all of the individuals who made this an engaging process. Thank you so much.